Great. Welcome. My name is Elizabeth Morera. I'm a healthcare administrator currently leading programs for LISC's Pawtucket Central Falls Health Equity Zone. I'm the director of operations for Project Health CV and a proud board member of Primary Care for All Americans. Thank you for joining us tonight. We now have representation of over thousands of people from over 40 states and the District of Columbia and 350 zip codes. It's truly inspiring to see how far we've come together and how the momentum to primary care to get primary care to everyone in America is spreading around the country. Speaking of how far we've come, tonight we are celebrating the 1 year anniversary of our Zoom teach-in learning events. Over the past year, we've worked hard to build a community of volunteers who are working together in their own neighborhoods and supporting communities as they take the charge of the process of providing primary care to everyone. Thank you all for learning with us and being part of this incredible journey. I'm thrilled that we are going to learn about integrated primary care tonight from Julie Oimaja and Sandy Blunt. Please stay with us until the end of the session when our board will join Julie Oyemaja and Sandy Blount for a Q&A discussion. We'll be exploring how you can help bring primary care to everyone in your neighborhood and community. Now it's my great pleasure to introduce our moderator for this evening, Gabrielle Yaru, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to thank the Zoom Committee of Primary Care for All Americans for organizing this event, as well as John Wright, Brian Kaiser, Patty Armstrong, and Liv Varaday for their hard work and dedication. It's all yours, Gabby. Take it away.
Thank you so much. Hi, everyone. I'm Gabrielle Yaru, a family physician at Jamaica Hospital Medical Center in Jamaica, Queens, New York. I want to start by thanking you all for being here tonight. By showing up, you're helping us build a movement, one that's focused on providing healthcare for people, not for profit, in every neighborhood, in every community, primary care for all Americans. Please take a moment to share where you're from in the chat so we can all see who's joining us as we work together to build this movement. Please exclude professional titles so we can focus on the importance of being here together, engaged in this work, and the value of the ideas and commitments that will ultimately drive this movement forward. Tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them into the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speakers. Now, it's my great pleasure to introduce our keynote speakers, Julie Oimaja and Sandy Blunt. Julie Oimaja is a practicing psychologist, relational community organizer, and scholar who directly supported the development of high-quality primary care in numerous organizations in Portland and beyond. With her on the ground, learnings creating interprofessional primary care teams, integrating behavioral health clinicians, community health workers, and psychiatric consultants, she and a team of interprofessional colleagues founded and developed the Interprofessional Primary Care Institute in 2018. The IPC Institute is focused on supporting high-quality primary care, which is interprofessional primary care team practice. High-quality primary care was redefined by the National Academy of Science, Engineering, and Medicine in 2021 to be the care delivered by interprofessional teams. The IPC Institute developed in 2018 to specifically support this kind of primary care practice. Sandy Blunt is the guy who made the integration of primary care and behavioral health happen, the guy who wrote the book and started a movement on its own. He is a professor emeritus of family medicine at the University of Massachusetts Medical School, where he founded the Center of Integrated Primary Care. He is the president of Integrated Primary Care Incorporated, a member and past chair of the AHRQ National Integration Academy Council, past president of the Collaborative Family Healthcare Associate, and is involved with writing and editing various healthcare books. Before we dive into our topic tonight, we're going to start with an exercise and reflection from Julie.
Thank you, Gabrielle. Good evening. As was shared, I'm a psychologist and the founder of the Interprofessional Primary Care Institute. I'm a longtime advocate for high quality primary care for all. The National Academy of Science, Engineering, and Medicine redefined high quality primary care in 2021. They defined high quality as the care provided by interprofessional primary care teams who are reflective of the neighborhood served. This is the kind of primary care I support. Mostly, I've developed interprofessional team practice in federally qualified health centers in my home state of Oregon, but I have supported in other states as well. My hope for tonight is that you leave understanding why interprofessional primary care practice is now considered high quality and why the behavioral health clinician role is essential for that high quality care. I've shared about interprofessional primary care teams reflective of the neighborhood served for years. Most understand this care when they get to actually see it through shadowing or experience it as a person receiving care. We cannot see it tonight or experience it. The next best way to explain interprofessional primary care practice that includes a behavioral health clinician, a BHC, as an essential team member is through narrative, storytelling. I wrote a personal narrative for you that I would like to share. I hope that through my story, you'll see why I advocate for high quality primary care and why high quality is the care provided by interprofessional primary care teams that includes a behavioral health clinician like me. My story begins in 2008, 16 years ago. I was sitting in a large room at the back of the federally qualified health center I worked in at that time. All the clinicians sat in the same large room with desks along the wall and carts of charts in between. We were writing with pen and paper. Back then, that is how charting was done. I often got a cramp in my hand because of it, but I never took a chart home. It was after the clinic closed. The team worked head down and with diligence to complete their notes. The focus was palpable. Kids needed to be picked up from daycare. Dinner needed to be made. My 2-year-old son was across the street at daycare. I could see the daycare playground from the window near my desk in the shared workspace. I loved that he was nearby. The team was all women. Several of my team members were nursing mothers. There was a range of lived experiences and professional training present. Several of my team members were in cross-cultural relationships, and their children were multiracial. The multicultural family background of so many of my colleagues was an important quality of this experience that made it very special to me professionally and personally. My husband immigrated from Nigeria at that time we were married for 3 years. Actually, in a couple of days will be our 20th wedding anniversary. These professional women were dedicated to health equity in 2008. They lived and breathed it in their personal lives and in our work together within the diverse community we served in the community health center that served in the neighborhood where I lived, my husband lived, and my son. The team was professionally diverse. The collective healing know-how was impressive. The collaboration between professions was easy and delightful. The team included family physicians, OBGYNs, an internal medicine physician, a naturopathic doctor, an acupuncturist, physician associates, community health workers, a nurse midwife, registered nurses, and a psychologist resident. That was me. In that moment, I was professionally satisfied and content. As I also worked with focus to close my notes after clinic hours, one of my physician colleagues leaned over to consult me. She and I cared for many people together. All were vulnerable. Most lived with chronic pain. She spoke to me in a concerned tone. I see her now, wearily moving away a strand of hair that chronically fell in front of her eyes. She began sharing about a person in our shared care. The person was on high doses of opioids for chronic low back pain, and they were requesting more opioids, and the request was not safe. She was worried. Physicians were taught at that time that it was inhumane not to treat people experiencing pain with opioids. We didn't have the perspective or solutions we have now for prescription-related opioid use disorder. We did know it was a problem, but we did not know how big a problem it would become in the lives of the people we served and in our society as a whole. We didn't have all the solutions we have now, but what we did have was powerful and way before its time. We had a high-quality, neighborhood-reflective, interprofessional primary care team. We didn't have all the answers, but we did have the resources we needed, and we made use of our resources. Our interprofessional team practice allowed us to seamlessly share about and support the biological, psychological, sociological, and spiritual needs of the people we served. We had diverse professional know-how to strengthen each other in the shared care of the most complex of concerns. We didn't have all the answers, but we had more than most primary care practices have today to care for complex needs. With our team, we were able to meet the great majority of healthcare needs that people present with. This work was very good, and I'm very proud of it. This kind of interprofessional primary care practice team, reflective of the neighborhood served, was progressive in 2008. In 2024, we can ensure this kind of care is available in all of our neighborhoods and for all of our neighbors. That is why I and my institute are delighted to be a part of this movement to ensure primary care for all Americans. It is time that all Americans are supported in such a rich and effective manner throughout their lives and in their own neighborhoods, at their usual source of care, primary care. We have many challenges in primary care today. Electronic medical records are a burden. There is a shortage of clinicians. Insurance companies seem off the rails. The people who do the care and receive it are disempowered when they should have the power in the system. But what unites them then and now is the power of interprofessional primary care teams, which communities can build for themselves and even pay for themselves. This kind of care is the definition of high quality today. Teams that make sure every voice is heard and both prevent and treat all manner of disease and causes of disability. Truly, together across our lived experiences and professional training, we make communities stronger. And with that, my story, that's the end of it. I'd like to pass the mic to my friend and colleague, Sandy Blunt, and Sandy will talk more about the essential role of a behavioral health clinician on interprofessional primary care teams, an essential role that ensures primary care is complete, whole person care that people need and increasingly want, a type of care that makes exceptional use of limited healthcare resources and should be available in all of our neighborhoods and for all of our neighbors. Thank you.
Thank you, Julie. I'm going to start at the other end of the process and talk about the people coming in the door. The people that we call patients. And I'm going to, if you don't mind, use that term, as long as we understand that I'm a patient in lots of settings and all of us are patients in some settings. It's not a description of anybody in terms of their whole lives. People come in and they present problems and pains in primary care. They present things where they don't know what's wrong. And the primary care role, one of the important roles, is to help figure out what's wrong. And the pains that people have are not either biological or medical or emotional or psychological. They are blended. They are in fact, statistically, the people who have the most burdens of chronic illness are likely to have the most burdens of behavioral health problems, which are mental illnesses or problems, substance use problems, problems of coping with illness and coping with life. And so without behavioral health, in primary care can't do its whole job of being the place to go to when you're not really sure what's wrong, and let us help you figure it out and make a treatment plan with you. Um, the the fact of primary care behavioral health is different a bit than what we think of as mental health in specialty mental health settings. It's something that can be useful for people who experience themselves as having medical illnesses. I mean, if you have a pain in your chest, you could have a heart problem, you could have a lung problem, you could have a bone and muscle problem, or you could have a panic attack or anxiety, any one of those. And often people experience stress, experience depression in terms of pains. And without having a team working together where we can address what you're ready to address and what's most urgent with you, it's a very difficult to provide whole care. And patients want their care in primary care. If a primary care provider says to a patient, I think you're coping with depression here, and I'd like to refer you to a treatment at the mental health center, depending on the population, somewhere between 25% and 95% of those people will never have a first visit at that mental health center. It isn't something that people will do or can figure out how to do. It just doesn't work. So we learned in a study in 1978, and it hadn't changed since then, that primary care is the source of, by far, the most mental health treatment in the country. So we need to have the team there, which Julie's described. We need to, primary care behavioral health is like primary care in the sense that it tends to be catching things earlier. It tends to go quicker. It tends to be shared information that patients will say, thank God you're finally talking with each other. Why don't you people talk with each other? And it tends to be a place where, with this conversation, this team conversation, can begin a process which ultimately now is leading to adding an additional expert to this team. And that additional expert is the patient themselves. And so there are lots of ways that the patient not only can read their notes, but can be brought in to be partners with their clinicians in their care. And that is now the cutting edge, not just how we array the team to serve folks. And I think I used all my time. As you can tell, once I get wound up, I could go for weeks. So I'll shut up here. Yep, see, I did use all my time.
You guys did great. Thank you so much, Julie and Sandy. If anyone has any questions for our keynote speakers, please post it in the chat. By joining and learning how communities can provide primary care to everyone and bringing one new person or more each week, we'll build this movement together. How did you invite someone new? Anyone on here that was invited to come tonight for the first time? Our work groups still need more people to roll up their sleeves and be a part of the work we are doing. Please click the volunteer button in the Contact Us section of our website to tell us how you can help. Together, we can make sure that everyone in the United States receives equal health care and gets equal health, regardless of where you live, how much you earn, what community you're from, or what you look like.
Well, thank you so much, Gabby. And thank you, Sandy and Julie. I think we're ready for some questions. If you want to start putting them in the chat, we will get to them as they come. We have a few questions that we are looking at now. We'll let Julie and Sandy sort of pop back in here. And the first question that I have over here is, the integration of behavioral health and primary care has expanded the scope of primary care practice, so that primary care delivers more of the services communities need. How can we best tell communities about these new services? What kinds of language should we be using? Julie, do you mind answering this for us?
Yes, absolutely, Patty. So this is primary care. And as Sandy described, primary care has always been the first place that we go. It's our usual place of care. And we have always brought our biological, psychological, sociological, even spiritual self and needs to our primary care practice. What we are doing with the integration of behavioral health clinician team member in primary care is just providing the appropriate support for people in the place that they want to receive care, and enriching primary care by the addition of these team members strategically selected to help ensure that we are actually providing biological, psychological, sociological, and spiritual supports to the needs that are being requested and have long been requested. So this is just looking at the needs of primary care, what the needs are now, what the needs have always been, and actually creating a team, like a powerful, diverse team that actually is equipped and designed to ensure that we're taking care of whole people. So it's primary care. We're just enhancing primary care and making sure that it has the supports. If you ask primary care clinicians out there or anybody who work in primary care, it's very hard work. And burnout is very high now, and it really has been for forever in the primary care space. It's because the needs are so great within our primary care space, and we just haven't had the staffing and the know-how and the team practices to actually meet the needs that have always been present there. So we're just advancing it, and that's why it's called high quality primary care. So we're moving from primary care to high quality primary care. We're doing it through interprofessional teams. It just makes sense.
It sounds like it makes sense to me.
Can I add just a comment on the word language? Because I like that was
Absolutely.
one of the things we need to do is use the patient's language for the problem. That if we talk about mental health as being and looking always about the diagnosis and using our distinctions in terms of services, a lot of people just don't want to be part of it. On the other hand, when we use words like stress and how stress affects your body and how stress affects your mood, people are right there. They say, yeah, that's me. What can we do? If we use terms like teaching people skills rather than therapy, like there was something, I don't know what that implies to people, but the idea that I can teach you skills to help you manage when your body gets nervous, when you get worked up. I can help you with your breathing. I can help you put yourself to sleep at night. Those kinds of teaching you something that you're perfectly capable of knowing, and when you know it, you'll do better, is so linguistically more acceptable to people. And that's got to be part of how we approach patients.
Wonderful. Yeah. And I think, from an approach, and even this might be the wrong term, but it's something that I use, is empowering people by speaking on an equal level with them. And so this next question, if I know we've got some people that will need to drop off at 9, but I want to get one more of these questions in here, and then we'll come back to questions at the end as well. But just talking about the top-down approach, as we are looking at this, Sandy, integrating primary care and behavioral health is really a top-down process. So we together are telling communities what services are available, how can we best listen to communities and hear what our communities want and need?
Um, to some degree, we need to talk to people about what they want and need, and to some degree, we need to offer people an explanation of what's available because a lot of people can't imagine integrated care. It it comes with all the stigma of separate mental health care. It comes with feeling like, oh, one more thing that's standing between me and my doctor. And so when Steve Jobs invented the iPhone, people didn't know they were missing an iPhone until they had an iPhone. And then they said, oh, yeah, this is good. Let's do this.
Yeah, now I turn back around and go get mine.
Yeah. And so that the culture of working in integrated care affects patients dramatically. They like it. They'll be happy to talk about it and they're how much they like it. But if you say to somebody on the street, I'm going to have a mental health person working in primary care, until they've had their issue addressed, until but the side of making them a partner, that's something that we can do once we get going.
That's wonderful. And there's so much more to talk to both of you guys about. I'm looking forward to coming back in just a few minutes to continue the conversation. But before we do that, I wanted to pass it over to Michael Fine, just to give us some information and let people know what's coming up next.
Thanks, Patty. And thanks a lot, Sandy and Julie, for being with us tonight and for your leadership over the years. Tonight you showed us how this bigger version of primary care brings communities together and how good that feels. And that's really different from this pain and the anxiety of the last week in particular. The pain we all experienced when we heard about an insurance executive shot down and heard about the outpouring of anger at health insurance, evidence that healthcare as we know it in this country is ripping this nation apart as opposed to pulling it together, which is what you showed us how to do by creating an integrated primary care approach. It doesn't have to be the way we have it. If the U.S. provided primary care to everyone, the cost of health care will shrink as our public health improves, and insurance companies and their absurd financial power will wither. The election's now over. There are no more distractions. Now's the time to change the reality on the ground. So don't throw up your hands, roll up your sleeves. Get one more person in your neighborhood or community. Get with 2 people or 3 or 5. Start a work group in your community in, the Pacific Northwest or in Amherst, Massachusetts, wherever. The way to do this is to build it from the ground up like we're doing in New Bedford, and in Queens, New York, and in Central Falls, and in Alexandria, Virginia, and in Cleveland, Ohio. It's important that we get started and we get started together. Remember that the cavalry isn't coming. There's no one to do this for your community. So it's time to stand up and connect. It's time to get started. This movement building thing is a crazy, huge undertaking. It doesn't happen in a moment and it doesn't happen in a day. Movements change things when a small group of thoughtful, committed, dedicated citizens see how much they can do together, go to work in their own communities, win small victories, and have big parties, and then start again, infecting others with the enthusiasm of what we can do together. Remember that health care impacts every single one of us. But when we work together, there's nothing we can't do. We're the public in public health, and the time to get started is now.
In about a month, we'll be meeting again. We encourage everyone to invite someone new to get involved in this impactful movement. Let's continue growing and making a difference together. Mark your calendars for our next Zoom meeting on January 14th, when we'll be releasing the new amazing PC4AA local playbook. We look forward to seeing you there. And look for the PC4AA local playbook, which will be appearing in your email in the next 2 weeks. And share that with friends and colleagues. Register on our website, www.primarycareforallamericans.org. And while you're there, click volunteer in the Contact Us section of the website to tell us how you'd like to be an active part of our movement. And please click donate to support our efforts with a contribution. Every little bit helps and makes a big difference in advancing our cause. Now, I'd like to introduce one of our board members, Pat Tokars, who will share why donating to primary care for all Americans is so important.
Thank you so much. And thank you, Michael, first of all, for giving birth to this movement, but to everyone on this Zoom for continuing and breathing oxygen into this movement. And if you think about it, most of us, if you look around on the screen, we've been doing parts of this in one way or another for many, many years. And we all know the problems. We all feel overwhelmed by just how bad it keeps getting. It just seems to get worse and worse each year and each decade. And I think this movement that each of us in our own way on this call tonight are contributing to is our last best hope to try to turn this thing around. As Michael just said, it's not going to be from the top down. It's got to be from the bottom up. And you and I can't change this whole thing overnight, and we can't change the whole thing for the whole country. But each one of you can do something in your local community. And that's the magic of this. But in order to coordinate this, I'm just astounded at how much has been accomplished. If you think of where this movement has gone from a year ago, it's phenomenal just how it's grown, how many more people are involved, how much more sophisticated the Zoom meetings are. And 98% of it's been done by volunteers. And folks, we need to get past the volunteer stage. We need to get to some real expertise, some staff to be able to grow this thing and get this thing really taking shape nationwide and in every local community. And this organization needs to know that there's going to be a certain amount of dollars coming in. And that's why not just giving once, but giving monthly just appeals to me as the most logical way to continue to make a difference. You know, I've been talking about this for years. I want to be a part of embodying this and actually making it come true. And each of us can donate some money, and we can figure out how much we can give on a monthly basis. And I can't think of anything more important to do with our money than to fuel the fan of this movement and get this movement to continue growing. So thank you.
Thank you. And thank you all for joining us tonight. We appreciate every single one of you for helping to spread this movement across our nation in order to get the change you deserve.
Well, we ask you guys to complete a survey. This information helps us to collect data around what direction we should be going in the future. The link I just dropped in the chat. Again, we do want to hear from you. We are trying to build a community here. Speaking of which, we're going to get back to some questions, both with our speakers and with the leadership team from PC4AA. If you do need to hop off, we understand. We're going to stay on just for a little over 20 minutes, maybe, as long as you guys keep the conversation robust. But we will see you on January 14th if you do need to hop off at this point. But for now, it looks like we've got some friends staying with us. Keep adding questions into the chat as we go, but I'm going to scroll back up here and talk a little bit more with Julie and Sandy, because as you heard, we have a local playbook that's going to be released on January 14th. And so we've got questions about this community building. So our local work groups include both community folks and health professionals. How can we make sure the behavioral health sector isn't its own section, but really integrated in? And who else really should be at the table in these conversations?
What a fantastic question. Well, I can speak from my positioning in Oregon, and the community the community of behavioral health clinicians who do integrated behavioral health and primary care are passionate, and they are advocates, and they self-convene themselves in our state. So I would suggest maybe seeing if that might be true in your community too. And one good place to look for where that might be the truth, and Sandy can tell a little bit more, is through the Collaborative Family Healthcare Association, which is the national entity that supports integrated behavioral health and primary care. You might not have known that for a long time, there is an entity that particularly supports the integration of behavioral health into primary care and other healthcare settings. So CFHA is a place that you will find those kinds of behavioral health clinicians, and we are a group that is very engaged and advocating. Saying that in your local community, there should be places to connect with. Uh, Particularly, I think about our community mental health behavioral health centers. They're a good place to start. The conversation about integrating behavioral health and primary care is long-standing in the mental health community. So there may be likely conversations in your community with behavioral health specialists. They just maybe aren't in the conversations that you're having within primary care or the spaces that you want to bring them. But it's likely that there are behavioral health specialists and behavioral health clinicians within your community that are already well aware of integrated behavioral health and primary care, as well as integrating primary care into behavioral health, which is a topic perhaps for another day, but also is primary care. So I wonder if Sandy has other thoughts about that.
Cindy, you're on mute.
All right. Well, I thought I said it right. That's a joke, folks. I think you're going to have to talk to some policy people, and the policy people, the word to use is access. That you're offering people, when integrated care is done well, when integrated behavioral health is part of the basic infrastructure of a primary care site, you're talking the likelihood of same-day connection, that someone's problem is either identified or they bring to primary care. We can get you connected today. And when you talk to outside of primary care, we're talking crazy waiting lists, months and months. And so, and it is the lack of access that is infuriating the populace, if you'll pardon the term. So access is a very big deal. And around issues, I mean, there's so many issues driving. There are upset issues on both sides of issues that are having people feeling desperate and feeling the ground under their feet getting shaky, and knowing that you could engage someone about how stressful that is, and then the fact that, and likely, we can help you get back on your feet pretty quickly. It's a very different kind of process.
Can I pull you out on that a little bit?
Yeah.
We're proposing a whole different approach to healthcare and health policy.
Yeah.
And that is, instead of, asking for someone in a state capital or in Washington to change it for us or to fund it for us, we're about trying to figure out how communities can do this for themselves.
All right. Well, maybe instead of saying who you go talk to, I'm talking about the flag that you carry.
Right. But here's how do we make sure we get everybody involved? And this is true of pharmacists and physical therapists. Um, in some communities, the people who will be convening local work groups may be musicians. In some communities, they may be plumbers. In some communities, there'll be family doctors. In some communities, there'll be nurse practitioners. And in some communities, because of this energy, it would seem to me they can be convened initially by mental and behavioral health folks.
Yes.
How do we help people who have been, sort of in the mental and behavioral health world feel comfortable about stepping up and bringing and putting together a local work group as one of the founding members of that
I like,
change?
and so let's go back to your playbook, because there will be people there. And when Julie talks about how us folks who've been behavioral health people in primary care are used to advocacy, she's absolutely right, because we've been advocating and explaining ourselves to our colleagues for most of our careers. We've had to explain to the financial people and the clinical people what it is that we do, and how come the doctors like us so much, and how come the patients get happy, because you're not in there that long and you don't see them for that many visits. How can this happen? And so the most of us have learned other skills that we had to learn in order to support the basic work of integrating behavioral health.
I just want to piggyback on what Sandy said, as our community is so skilled in advocacy. But my institute is a good example of how this can work well. It's an interprofessional primary care institute. It's run by a psychologist. It's conceived of by a psychologist. That's not usual in the primary care or the medical space, but it is a psychologist that is leading an initiative to create interprofessional primary care and provide an education platform for this high quality primary care. So that's an example of the kind of advocacy that is within the integrated behavioral health space that you just need to tap into. But the other thing is that, as an example with my institute, is that it was started by a group of interprofessional practice directors. So we built a team that was reflective of the teams that we wanted to see built in practice. And then we worked on our interprofessional skills as a team, building an institute that is fully reflective of what we wanted to see develop in primary care. It's the power of these I have a clinical pharmacist that I see, Ashley, down there. It's my friends in PT. It's my family physician friends, my internal medicine friends, my pediatric friends, my nursing friends. When we just step out of our silos and find each other in these different professions that we've always needed in the primary care space, working as teams, that's power. But I will say, it's not without challenge. We have been trained to think by ourselves with the people who are in our same professions, trained by people in our same professions, practice with people in our same professions, and we just lose out on huge amounts of power to change the system. So if we can, across our professions, find each other and say, hey, we care about primary care, and we see that it is a biopsychosocial, cultural approach is absolutely necessary. And we need each other to do this in teams. If we actually, that's so many people. It's so powerful. So I guess that's what I would say, is there are so many people within just the professional space alone, not to mention all the people who receive primary care, which would be all of us. There is so much power in the people who we need to be providing primary care in this interprofessional way. There's so much power in the people who receive primary care. If we can just activate those two places, we're activating everyone, and so much power for change of primary care. But we do have to fight against this mental model of primary care that's really outdated.
That is such a important thing, I think, Julie, as we talk through this. And I saw a few questions as I was scrolling back. I think Pat Tokars, you had brought up this question of, where do we get started? And my next question in here is also about listening and engagement. And I think that's a lot of what perhaps I'm hearing through these discussions as well, is as we are getting started in our different worlds and realms, what is that first step? And I think it is grounded somewhat in the listening and engagement piece. But Sandy, you are so foundational in sort of this thought process, as we've heard. What would you say are some of those early things that we need to be listening or engaging with in this process as well? So you'd have to come off mute, but I do want to hear what you have to say.
In the process of engaging people in the movement, is that what I'm understanding?
Engaging and listening, like what should we be doing, right? Like a little call to action here.
I think it's helping people in very plain language about what they need and what we have a right to. That if we talk about services, I couldn't sell integrated care to anybody but I can sell having someone who can deal with my stress as well as my pain in primary care. And that if we're demanding, if we're talking about how this has to be, yeah, we might translate it for some people, but mostly we're talking about when someone comes in to your doctor, we want you to be able to have a doctor, for that doctor to have the team that she needs to be able to engage with you and to meet the needs that you're going to bring with her. And we need to have enough other doctors so that you aren't one of 2,000 or 2,500 people that she has to take care of. And the team needs to have people who can address your stress and your substance struggles and your fears, in addition to your diabetes.
Yeah, this whole person sort of approach. I saw somewhere, Paul, I love when you type in the chat, and you said something about toxic individualism. And you always have such great questions to ask about. Did you want to expand on that a little bit and just sort of what you're hearing here?
Thanks, Patty. I'm an old fart. I practiced for 39 years and you kept trying to fight the same battles, So I keep on my desk this little model of Sisyphus pushing the rock up the hill because that was my practice. Nothing I ever did worked. And I've come to conclude that toxic individualism is poisoning the whole country. We forgot what community is. We don't remember town halls. We don't have a bowling league. We don't belong to civic institutions. Everybody's trying to fight 2 or 3 jobs in order to live in late stage capitalism. It's just poisonous. So, we need to go back to community. I mean, people can't stand some words. Their buzzwords will drive them crazy, but nobody hates community. Not really. So I'm looking at a bunch of faces of people who all agree with me, and we're all trying to do the same thing. We got to figure out how to collaborate. And it is not individualism. It's working together, collaboration. That's the name of the game. And everybody's nodding their heads because we all agree. You just have to build it out.
Just got to start it. And what I'm hoping is that the special skills that folks who are trained around behavioralism and mental health can help us activate communities so that they take this up with us, so that this is everybody together. Because if, the family doctors in the room try to do it by themselves, it's going nowhere. If the pharmacists in the room try to do it by themselves, it's going nowhere. If the physical therapist in the room, if the behavioralist in the room, but we have to find the language that gets everybody on this call to finish this call and tomorrow call up one other person and say, we're going to sit down and start a local work group in this place where we live. And it's those skills that we need, sort of help with around language and activation, because this moves when we don't have 5 local work groups, but we have 100 and then 200 and 500 and 1,000. The challenge is getting started like that.
Absolutely. And I agree wholeheartedly with that. My role in my everyday life is I'm in resource development, and I tell people each and every day I would love for organizations to run off of passion alone, but no one wants to get paid in words of affirmation. So thank you, Pat, for your call to action for people. I also saw you bring something up about paying for the range of services. Do you mind just asking a little bit more about that, talking about it?
Just some practical things I'm a strong believer in independent practices, and I've seen the teams work, but it's in a federally qualified health center. It's in a big, huge multi-specialty clinic setting. It's part of Kaiser. But in terms of trying to keep smaller practices alive, how do you get started? And is there a blueprint for figuring out how do you just figure out how do you get paid through the insurance companies if you're going to integrate behavioral health and health coaches and all these team members? How do you get started and what are you trying to build towards? But my bigger question is just what you were talking about a second ago was how do we do this in our own communities? And it's kind of intimidating to think about, okay, I'm one person and I'm going to create this movement that's going to transform healthcare in my own hometown and my own community. What we hope is that the local playbook, which is going to be released in a few weeks, will give you enough information to help you jump off the cliff and just give it a try and then see what happens. But our real goal is to try to get this local playbook to be continually evolving. So as you try something and it does work or it doesn't work, it's gonna be an open source document where you can write in there and update it, and we can all help each other through this evolving playbook as sort of our written record of what we're doing around the country. We can all help each other be more successful in our own communities by sharing what we're doing locally with everybody else in the country. So it's 2 questions. One, the practical thing of this teamwork is great, but how do you actually pay for it? And number 2 is nobody's crazy enough to start a national movement to try to transform healthcare at the local community. But if we're going to do it, we got to do it together. So how can we continue this feeling that we have on these monthly meetings in a practical sense as we're trying to meet one other person and then 4 other people and bring in a behavioral health person to the discussion? We can continue to help each other through this living document of the local playbook.
Well, I got 2 things for you, Pat. One is what I call the emergence, and the other is just working with the status quo. And you can do it in both places. You could do it. This is the good news, is you can actually do it in both places if you got the passion and will and have those community building skills. It is so possible. Emergence, what I would like to see goes along with the playbook. It's something emerging that is not held back by anything that we currently have in place. It's what can be, and what can be is not that expensive. This idea that I really like is partnering with the local chamber of commerce. Those are your business leaders. There is so much money already in our communities. Taking an approach that identifies we already have resources in our local communities. We have assets. And does everybody in the community want primary care?
Yeah.
Yeah, they do. Do they all have access to it?
Nope.
No, they don't. And if you go, so I recently got involved, I just with a local small town rural chamber of commerce, and I just found all kinds of power within that space. And I was like, oh my goodness. So this is in every single town. There's these chambers of commerce where they're already convened. People who are already
Close.
employers, who are already paying tons of money for insurance. They're just ready for people who are like, hey, do you want to have primary care for all your people that's not only less expensive than what you're paying right now, but we could build this team in our neighborhood that includes a psychologist too, maybe even an acupuncturist, a naturopath. What do you think? Community health worker, how much do you think that would cost? It was like, oh, it's not that much money. It's really not. Truthfully, it's not that much. That's the emergence, and it is completely possible. And it may even be the path of least resistance. But the other one is the status quo and just doing what I'm a psychologist. I'm a practicing psychologist. I make a lot of money billing insurance companies if I have a support system that helps me bill the insurance companies, just like a physician. We are find a licensed behavioral health clinician who can bill for services and get a good return for a variety of different. I'm on a ton of different insurance panels, and I work for an organization that works well in getting me paneled up and has a process that helps me bill for things, and I do well. So there's a myth out there about behavioral health clinicians. We get impaneled just like any other licensed clinician, and we do quite well with a whole set of billing codes that we bill that are just different codes than physicians in primary care tend to use. So we can certainly be sustainable in the status quo. It may not be the path of least resistance, though, which is what I want to bring attention to. It actually might be easier in your local community to do the emergence.
This is so good, and I wish we could keep going, but it is 9:30. We do want to respect people's time. I am going to do one call out to Jennifer, if she's still on here. I know you're interested in getting involved in the Rhode Island group. I will pass that along. Make sure that you get involved. Go to the website and click on that. There should be a place to volunteer. We have local work groups actually in Rhode Island, depending on what area you are in. But this is really a call to stay involved, get involved, enjoy your holiday season, and then come back with a friend or 15 in just a few short weeks. It'll be January 15th before we know it. Michael, anything else to send people off with?
Just two things. As I said before, let's stop admiring the problem. Let's start fixing it. And fixing it means tomorrow, go out and grab one other person, have a cup of coffee together, and figure out how you're going to start a local work group. And it doesn't matter whether you are, a guitarist, an electrician, a psychologist, a physician, a nurse practitioner, a pharmacist. It doesn't matter. The whole idea is to start with somebody and start tomorrow, because if you put it off one more day, it isn't going to happen. So that's thing one. And thing two is if you can think about making a small monthly contribution, even if it's $1. That adds up over time and really lets us do more and better things in many different parts of the country to support all these local work groups with helping people learn to be facilitators and bringing organizational support. We put all this money, we don't have very much money, let me tell you, but everything we get, we put to work to try to build a healthcare system that's for people, not for profit, and starts, as I always say, with providing primary care to everyone in every American neighborhood and community. Let's do this together.
Have a great night, everyone. We'll see you in just a few weeks.